Hello everyone. Today we are present here with another interesting lecture that is called the concept of stress or the transpulmonary pressure. Let us discuss. So what do you mean by stress? So stress in simple terms is equal to force per unit area, right? Is stress or pressure. So if you are giving that force to a larger area, that means stress will be less, right? If the same force we are giving to a smaller area, that means stress will be high, right? So this is the situation in case of ARDS. Because of the disease process, we have a very smaller area of lung to be involved. So if you use the same force or the same distending pressure in ARDS patient, it can cause a higher stress, and that will implicate higher chances of VILI and mortality, right? This is stress. So what do you mean by the transpulmonary pressure? From where this concept has come? So usually we measure the P plat in the ventilator, right? And we think that the P plat is actually giving us the pressure of the alveoli. That is what we want to know. But because we cannot measure the alveolar pressure inside the alveolus, we check the area pressure when there is no flow, and we think that that is the P plat, that is the pressure of the alveoli. And it is true in most of the cases. However, actually, if you want to measure P plat or in the ventilator, that is actually is equal to the alveolar pressure and the pleural pressure. Because in most of the cases the pleural pressure is negligible, so it turns out to be the alveolar pressure is actually equal to the plateau pressure. But there will be situation, for example, in obese patient, in abdominal compartment syndrome, or in thoracic cage abnormality. In these situations, what will happen is the P pleura is now not negligible. So this P pleura not negligible. In most cases it is negligible. So the plateau pressure that we measured on the ventilator is actually the alveolar pressure. But in this situation it is not actually negligible, so it is significant amount. So in this situation what happens is, now the P alveoli is actually the P plat on the ventilator that we measure, right? In ventilator we measure the P plat how? In volume control ventilation, square wave form, giving a tidal volume of 8 ml per kg body weight, putting an inspiratory pause of 0.5 second, 3 second is ideal, and finding out the P plateau pressure. That is the P plateau we are talking about. So in this situation, because we have a significant pleural pressure due to all this pathology, the P alveoli is actually less than P plat that is on the ventilator. But how to know the exact P alveoli? That is your question. And second thing is, because P pleural is now significantly positive, what it will do is it will cause end-expiratory collapse of alveoli, right? So now let us come to this image. See, this is the lungs, this is the pleura that is surrounding it, and it has a pressure that is called the pleural pressure, and in the alveoli it has alveolar pressure, we have airway pressure. So what do you mean by transpulmonary pressure? So transpulmonary pressure is equal to the pressure that is required to move the air from the airway to alveoli, plus secondly it is the pressure to overcome the elastic recoil of lung tissue, right? This is actually not a very important thing in a normal healthy patient, but this becomes handy in ARDS patient. In ARDS patient this becomes a very significant issue, right? So this is otherwise this is also called P airway minus P alveoli plus P alveoli minus P pleural. Air will first come from here to here, there has to be a pressure difference, and from here to overcome the elastic recoil the alveolar pressure has to be more than the pleural pressure, right? So this is the transpulmonary pressure. Subjectively how to define it? This is actually called alveolar distending pressure. This is the pressure that distends the alveoli. You give air, it is coming and it distends the alveoli, right? It's called alveolar distending pressure. So now let us discuss how to measure it. From this equation here, so P flat is actually equal to, that is in the ventilator, P alveoli, this is the true P flat, the true P flat, right, plus P pleural pressure. So this is a true P flat or true pressure of the alveoli can be measured. It is equal to P flat, that is on the ventilator, minus P pleura. As you have seen in most of the cases this is negligible, so these are the same. But in cases where patient is obese and there is abdominal compartment syndrome and there is thoracic cage abnormality, there it will be significantly positive. So in that situation you have to measure this. How to measure this? This is measured by using esophageal balloon pressure. So we put a esophageal probe and measure the esophageal balloon pressure, which actually acts as a surrogate for pleural pressure, right? So if you measure the esophageal pressure, that will actually act as a surrogate of pleural pressure. So if you can negate the pleural pressure from the Plateau pressure that we achieved on the ventilator, we will get a true P flat, that is the alveolar pressure. This is the actually alveolar pressure, distending pressure. This is actually the alveolar distending pressure, or otherwise it is called the transpulmonary pressure, which is equal to P flat in the vent minus P esophagus, which is a surrogate for pleural pressure. This is how we measure the transpulmonary pressure. This is very, very important, right? What is the implication? Implication is, for example, the transpulmonary pressure has to be positive always, because it is the alveolar distending pressure. If it is not positive, if it is negative, then there will be collapse of the alveoli, because it is the pressure difference between the alveoli and the pleural pressure. So the alveolar pressure has to be more than the pleural pressure always. Otherwise, if the pleural pressure becomes more and the TPP becomes negative, then it will produce a back pressure on the alveoli and the alveoli will collapse. There will be atelectasis, derecruitment, right? So the TPP has to be positive always, but not too much positive so that it produces barotrauma. So what will happen? So during inspiration, measure the P plat that is on the ventilator, right? And secondly, measure the P esophagus. So for this, you have to put a esophageal probe and measure this. And the difference P plat minus P esophagus during inspiration should be less than 25 centimeter of water. Ideally, it should be, the ideal condition will be, it should be between 15 to 20 centimeter of water. If it is more than 25, there will be barotrauma or VILI. Less than 25 centimeter of water, there is less chance of VILI, right? If it is there, less chance of VILI. So during inspiration, this P plat that you are measuring on the ventilator, that is actually you are thinking it is P alveoli, but actually it's not P alveoli. That is the reason why you have to negate it from the P esophagus, which is surrogate for P pleura. So if you negate these both of the things, you will get the transpulmonary pressure, and it has to be less than 25 during inspiration. And during expiration, what happens? During expiration, the P plat that is on the ventilator is actually the PEEP, because during the expiration, the only pressure that is remained in the lung is the PEEP that you have given, right? Also at the same time, you measure the P esophagus during expiration. That will be a surrogate for P pleura. So here also, P plat on vent, that is equal to PEEP minus P esophagus, that is equal to P pleura. This should be a positive value, usually between 1 to 10 centimeter of water, so that there won't be any end expiratory collapse. If it is positive, there won't be no end expiratory collapse, because the pleural pressure is not more than the alveolar pressure. If it is a negative number, then it will compress on the alveoli and collapse them, and there will be derecruitment. So this has to be always positive, right? So we have to adjust the PEEP in such a way that it is more than the P pleura, which is measured as P esophagus, right? Then there won't be any end expiratory collapse. Same goes for inspiration. It has to be less than 25 to prevent barotrauma or VILI. During expiration, it has to be a positive number between 1 to 10 centimeter water. So this is how the transpulmonary pressure can help us preventing VILI in our patient. Thank you very much.